clinical story: myotonic dystrophy type 2, DM2, proximal myotonic myopathy, MM. Mr. Ramesh, a 48-year-old school teacher, visited the neurology clinic complaining of gradually progressive stiffness and pain in his thighs over the past 6 years. He recalled that the symptoms had started insidiously in his early 40s. Initially, he noticed a peculiar stiffness in his legs whenever he got up after prolonged sitting. Climbing stairs, rising from a low chair, and getting out of a squatting position gradually became difficult. Unlike many muscle disorders that begin in the hands or feet, his symptoms predominantly involved the muscles around the hips and shoulders, suggesting a proximal pattern of weakness. As time passed, Mr. Ramesh developed an unusual type of muscle pain. Some days it felt like a deep, dull ache in the thighs, while on other occasions it was sharp and stabbing. Interestingly, the pain was not always symmetrical. At times, only one thigh would be severely affected. He found this pain puzzling because it often occurred even when he had not exerted himself excessively. The pain and stiffness fluctuated considerably from day to day, with some mornings being particularly troublesome. One day, while shaking hands with a colleague, he realized that after gripping firmly, he had difficulty releasing his hand immediately. He noticed similar problems while opening jars, holding tools, or gripping door handles. However, he also observed an intriguing phenomenon. If he repeatedly opened and closed his hands or walked for a few minutes, the stiffness gradually disappeared and movement became easier. This characteristic improvement with repeated activity, known as the warm-up phenomenon, is a hallmark of myotonic disorders. Concerned by his progressive symptoms, Mr. Ramesh sought medical attention. During neurological examination, the physician observed mild weakness predominantly affecting the hip and shoulder girdle muscles. When asked to grip the examiner's fingers tightly and then release, the relaxation phase was delayed and occurred in a jerky manner, demonstrating grip myotonia. Percussion of certain muscles also elicited delayed relaxation. Distal muscle strength was relatively preserved, helping distinguish this condition from classic myotonic dystrophy type 1, which predominantly affects distal muscles. Further questioning revealed several important associated features. Mr. Ramesh had undergone cataract surgery at the age of 45 because of premature lens opacities. He had also developed frontal balding and was recently diagnosed with type 2 diabetes mellitus. Although he denied palpitations or syncope, the neurologist explained that cardiac conduction abnormalities can occasionally occur in this condition and advised cardiac evaluation. Family history disclosed that his father had experienced similar muscle stiffness and had undergone early cataract surgery, strongly suggesting an autosomal dominant inheritance pattern. Electrophysiological evaluation was performed. Electromyography, EMG, initially appeared normal, but after careful examination of multiple muscles, characteristic myotonic discharges were detected. Serum creatine kinase (CK) levels were mildly elevated, indicating ongoing muscle fiber damage. Muscle biopsy demonstrated dystrophic changes similar to those seen in myotonic dystrophy type 1. To establish a definitive diagnosis, genetic testing was ordered. The analysis identified an expanded CCTG repeat mutation in intron 1 of the ZNF9, also known as CNBP gene, located on chromosome 3q21, confirming the diagnosis of myotonic dystrophy type 2, DM2, also called proximal myotonic myopathy, PROM-M. The mutation leads to production of toxic RNA molecules that trap important RNA-binding proteins, causing abnormal splicing of several genes, including those encoding ion channels, thereby producing myotonia and multisystem manifestations. Mr. Ramesh and his family were reassured that, compared with myotonic dystrophy type 1, DM2 generally has a more favorable prognosis. Most patients remain ambulant for many years and do not experience the severe progressive disability or early cardiorespiratory complications typical of DM1. Nevertheless, regular follow-up was advised to monitor muscle function, cardiac status, cataracts, and metabolic complications such as diabetes. Thus, the classic clinical picture of DM2 PROM is an adult with proximal muscle stiffness, pain, and weakness, fluctuating myotonia with a warm-up phenomenon, early cataracts, frontal balding, diabetes, autosomal dominant inheritance, and a relatively benign long-term prognosis.